Hello, this is Dr. Mobley here, signing in from home. I hope the weather holds up. I'm going to give a few more minutes for a few people to log in. I see there's a few still joining, and then we're going to get started on our prolapse webinar. There we go. Now we're getting some more people logging in here. I'm going to give it about 30 more seconds. Grab something to drink if you need it. Okay, well, I'm going to go ahead and get started. So today we are here to talk about pelvic organ prolapse, which is a very common urological condition or urogynecological condition that I deal with. Just a little background for those of you who don't know me. I am a urologist with Urology Austin. I am trained in female pelvic floor reconstruction. I did a fellowship in New Zealand, which wasn't technically solely devoted to this, but I did definitely a lot of female pelvic floor reconstruction, and that's where I learned the majority of what I know about pelvic organ prolapse. I did go to the Medical College of Georgia. I did my residency at the University of Utah, and again did a fellowship in New Zealand, moving to Austin from Auckland, New Zealand about 5 years ago. So, what is pelvic organ prolapse? Well, you know, in sort of real anatomical terms, what it is when an organ from the intra-abdominal or pelvic cavity slips from its normal position, being held sort of higher up in that pelvic cavity, into the lower pelvis, and then protrudes through the wall of the vagina, or sometimes falls sort of out of the confines of the vaginal opening outside of the body. Now, when you see prolapse happening, you don't actually see these organs. You see the vaginal wall pushing forward. So when you say you see it through, protruding through the vagina, what it means is you see the vagina bulging out or forward from where it should normally be sitting. And so essentially it's a hernia. And a prolapse basically can occur from any organ within the intra-abdominal or pelvic cavity, and it can include just a portion of an organ or the entire organ. And these are the organs, the following organs are the ones that can typically prolapse through the vagina. And you've got the urethra. Hopefully you guys can see my pointer. This is the urethral channel here. This is the channel through which urine exits the bladder out to the external world. You got the bladder, and this can also prolapse. This right here is the vaginal canal. So if you have a urethral or a bladder prolapse, what you see is the urethra sort of bulging right here through this lower segment of the anterior vaginal wall. The bladder, when it prolapses, starts to push this segment of the anterior vaginal wall out and sort of sometimes down through the vaginal opening, and I'll show you pictures of that in a minute. We've got the uterus, which can also prolapse from the top of the vagina down and out. If you weren't to have a uterus, or sometimes you can get this happening even with the uterus in place, you can get small bowel that falls behind the uterus, or if the uterus has been removed, it can protrude in this area where the uterus used to be through the top of the vagina. You can get the sigmoid colon, which is sort of the lower portion of the small intestines before you get to the rectum, that can fall down and prolapse. And you can get the rectum that can prolapse through this posterior vaginal wall, and it usually bulges forward and then sometimes down and out. Now, rectal prolapse is different. It's very confusing because rectal prolapse is actually when the rectum prolapses through the anus and you see the rectum hanging out of the anal canal. But a rectocele is the technical term for the rectum when it bulges through that posterior vaginal wall, but you're not having it come through the anus. So just to clarify that, because that can be confusing. This picture right here is normal anatomy. A few other points that are important to understand. These sort of this part of the schematic here, this red sort of striate appearing structure, those are the external sphincter muscles that sort of sit around not only the rectum and anus here, but also the urethra that helps keep us continent of urine, of feces, of gas. And there's also muscles down here between the vagina and the anus, the rectum, called perineal muscles. So that's what those pictures are trying to describe there. There's also, if you're looking at a picture or the body in a different view, you'd see sort of a bowl or plate of muscles that surrounds the pelvic floor. We call that the levator ani plate. That also helps provide a lot of muscular tone and support to the pelvic floor. So again, there are many types of prolapse, and what I specifically, sort of referring to in the office when I'm seeing you and evaluating you and doing your exam would be a cystocele, which is an anterior prolapse of the bladder falling down towards through the anterior vaginal wall, the urethrocoele when it's the urethra dropping, or a cystourethrocoele, which is a combination of the two, which is quite common. On the posterior side, we see rectocoeles and sigmoidocoeles. And the vaginal vault, or the apex, we otherwise will refer to that, or apical prolapse, can include the top of the vagina, called the vault, when the uterus has already been removed, uterine prolapse if the uterus and or cervix is still present, and enterocoele, again, when the small bowel drops down through that defect, usually when the uterus has already been removed, but also can happen when the uterus is still present. And this kind of gives you an idea, and it's hard for me to explain, so I'm glad we have these pictures here. This kind of shows you in concept what those areas that are prolapsing would look like. So normal anatomy, again, everything's sitting nice up and high. There's nothing dropping or protruding. So we have nice funnel-like effect between the bladder and the urethra. We got a nice sort of linear with a posterior tilt vaginal canal, the uterus sitting here. Cervix would be in this region. The uterus sort of tilts forward this way. Rectum, anorectal junction here. In a cystocele, what we'll see is the base of the bladder starts to protrude through this anterior vaginal wall, and you get that wall bulging forward. And sometimes it's just something I can see when I'm doing an exam, and a lot of women don't even feel that and notice it. It doesn't cause a problem at all. But once it starts to kind of get towards the opening, or what we call the introitus of the vagina, a lot of women will start to notice it. When they're taking a shower, they may feel something. When they're wiping, they may feel something there. Certainly when it starts to come outside of the vaginal opening. And again, it's the anterior vaginal wall that you see, but it's the bladder that's sort of pushing it forward. When it gets outside of the vaginal opening, that typically becomes really symptomatic for patients. Not to say stage 1 and 2s aren't symptomatic, rarely stage 1, but stage 2 can be. But when it gets to stage 3 or stage 4, it can be very symptomatic and really uncomfortable for patients. So that's the bladder drop. You can sort of imagine that this can cause some functional issues, because you see the angle now between the urethra and the bladder is much more acute, whereas here in the normal anatomy, you have that nice, again, funnel-like effect between the bladder and the urethra. It's much more easy for urine to flow. Here, the urine that's kind of up here in the top part of the bladder may flow out fine, but the urine that gets trapped here in this part that's fallen, sometimes it's hard to get that up and out of this sort of depressed area of the bladder where it's sunken in, and that can make it difficult for women to empty their bladder. Can also do a few other things, which I'll go through in more detail, but sometimes it can actually mask incontinence because it sort of kinks the urethra off right here. This is a picture of the uterus dropping, uterine prolapse, and we see this quite commonly concurrent with anterior vaginal wall prolapse or posterior vaginal wall prolapse. So these things do not often happen only in isolation. A lot of times we'll see multiple different areas prolapsing at the same time. And this last picture here is the rectal prolapse or rectocele. So again, we're going to call that rectocele, not truly rectal prolapse. Posterior vaginal walls bulging forward. And instead of this normal anatomy where you get the anus sort of coming straight down and out, which is really important for people to be able to have normal defecatory function or be able to poop normally, okay? What happens is when you get this posterior bulge, there's not proper support right here and stool gets kind of trapped in this pocket and then it can't make it over and out. So a lot of women will feel like they need to put a finger inside of the vagina to be able to give that support back and help encourage the poop to come down and out. And that's called splinting. So that's something you may get a question about. And a lot of women look at me like, excuse me, what? Did you ask me if I put a finger in my vagina to poop? No. But that's why I'm asking you that question. It's to make sure that I understand how bad, if you have a rectocele, how bad it may be and what kind of functional limitations it's causing. The prevalence of pelvic organ prolapse. So it's actually very, very common. So this study, the Women's Health Initiative, looked at US women aged 50 to 79 years old, and they found that overall prolapse, grades 1 through 3, which I'll explain to you in a second, it was 41.1% of the women in that age range had this grade 1 through 3 prolapse. That's a really high number. Not everybody is symptomatic, but this was doing a physical exam who has prolapse. And then they broke it down into anterior wall versus apical or uterine versus posterior wall, the rectocele. And the majority of the women had cystoceles, though you can see here that 14% and 18 to 19% also had the uterine and a rectocele. And again, most women, actually, I don't have the actual numbers here, but most women don't have isolated anterior or posterior or uterine prolapse. More often than not, we're seeing these things happen concurrently. So knowing that 41.1% of women in that age category have prolapse, well, how many of them actually ended up needing surgery? And the number is 11%. So there's 11% lifetime risk that you will need pelvic organ prolapse surgery if you're a female living in the United States by age of 80. And that's one of the most common reasons that women sort of in this later age range end up undergoing surgery is for pelvic organ prolapse. So it's really, really common. The risk for surgery increases with age. And the reason the risk for surgery increases with age because the risk of prolapse increases with age. Other risk factors include increasing parity. That means how many times were you pregnant? Age, like we just talked about. Postmenopausal status increases the risk for pelvic organ prolapse. Being overweight, which constantly puts a lot of pressure on your pelvic organs and the support structures that help keep everything in place, is a big risk factor for prolapse. Tobacco use or abuse, because it affects the quality and integrity of our connective tissues. So it can make them thinner, looser, weaker, all those sorts of things. We lose that nice collagen, get a little more elastin going on with tobacco use. Chronic lung disease, which can lead to chronic coughing, can increase that risk of intra-abdominal pressure, which pushes on those pelvic organs, and over time can cause those connective tissues to get thin, weak. Family history does play a role. So I see a lot of women who say, my mom had it, my grandma had it, my sister had it. There may be some inherent defect to the connective tissues in families. Number of vaginal deliveries, certainly increasing risk of, or increasing number of vaginal deliveries, especially compared to C-section, increases your risk for prolapse. And chronic constipation, again, because of the chronic straining. The risk of operation is repeat operations due to failure is about 20 to 30%. And it does depend on the type of operation that you had the first time. And if you have a subsequent operation, your risk for further surgery increases as well. And the time interval between repeat procedures decreases with successive repairs. Though I do think there's a difference between maybe using a vaginal native tissue repair and the risk of reoperation there. And then if you change sort of the strategy in terms of the repair and do maybe a different type of operation where you go in abdominally and use mesh to augment that repair, that is going to decrease your risk long-term of needing a second. But certainly if you're going in the same way, same time, same type of approach, you can expect the law of diminishing returns there. Okay. Oh, and there's about 200,000 pelvic, 200 to 300,000. I've seen those two numbers. Pelvic prolapse procedures or surgeries done annually in the United States. So again, a very common procedure. Other risk factors that I didn't quite mention. I think I hit on all those. Pelvic tumors is one that I didn't speak to, but again, anything that puts a lot of tension on the pelvic floor can increase the risk. Certainly, if you need surgeries to have those sorts of things removed, and a hysterectomy is also one of those surgeries, not necessarily for tumor, but hysterectomy in general can increase your risk for developing pelvic organ prolapse because there are certain supportive tissues or ligaments that help hold the uterus in place, and that helps to hold the top of the vagina in place. And once you've had a hysterectomy, those ligaments have been disconnected or interrupted or removed, and you may end up with a more significant risk for prolapse moving forward, and also stress urinary incontinence. So what might you experience if you have prolapse? Well, a lot of times nothing. I mean, many women have prolapse, and I see them in the office, and I do their exam and say, oh, you have a mild cystocele or mild rectocele, but they have no symptoms of it. It's more of an incidental finding. So certainly you may have completely asymptomatic prolapse. But if you are having symptoms, what might you expect could be some symptoms of it? Well, you can see or feel the organ protruding. And again, it's going to be a vaginal bulge. Some women will say, oh my gosh, I felt something in the shower, and then get the mirror out and see it. And instead of seeing the normal opening to the vagina, you just might see something sort of hanging there, and it'll look like vaginal mucosa. So it's sort of a pink or sometimes palish, pink, red, depending on your age, tissue. It looks a lot of times rugated, which means wrinkled, in younger, healthier patients that have not gone through menopause and their estrogen levels are normal, or sometimes it's completely smooth and more pale in patients who are more elderly, where they've gone through menopause and their estrogen levels are low. Sometimes if it's been rubbing on your clothes or your underwear, you can get ulcers, and you can see that. It can be red, irritated, sometimes bleed. And some women may actually present with some vaginal bleeding or spotting on their underwear, and they didn't really feel anything. They just saw this on their underwear or their pad, and that's how the evaluation got started. But it's from prolapse and the constant rubbing of that vaginal tissue, which dries it out and can cause it to bleed. Some women just feel a sense of a vaginal heaviness or a bulge without necessarily seeing it. Some people describe that as pelvic pressure. They feel like they're sitting on something like a water balloon or a ball. Some women just feel pressure without sensing a bulge, so everybody describes a little bit differently. There's not one classic way that women always say it that makes me think, aha, prolapse. It can be sort of a variable description of these similar sorts of things. Some women, it's just a heaviness down there. Some women will have painful intercourse. We call that dyspareunia. That's thankfully not a super common symptom, thank goodness. It tends to be more common in the more severe prolapses, but a lot of women don't really have too much sensation vaginally, actually, and they may feel a little bit more urinary urgency or frequency during intercourse when they have prolapse, but again, not very many people have that painful intercourse, so to speak. Urinary incontinence is a common concurrent symptom with pelvic organ prolapse, and it may not be the prolapse itself that's causing it. When it's stress urinary incontinence, it may be, again, something, you've got defects in the pelvic floor, both of the supporting structures holding the bladder, but also the urethra, and that can lead to incontinence. But specifically when it comes to prolapse causing it, it may be more urge-related urinary incontinence or urge incontinence, overactive bladder. And this is typically symptoms of urgency of urination, meaning, oh my gosh, I gotta go and I gotta go now, which is separate from frequency of urination, which is having to go a lot. And you can have those two things happening together where you have urgent, frequent urination, but they can also be separate. And sometimes they're very much related to the prolapse, especially for more severe prolapses, stage 2 approaching 3, stage 3, stage 4 for sure. But a lot of times it may not be related to the prolapse, and patients definitely have to understand if their main bother is urinary symptoms like urgency and frequency, but they've come to me to talk about having surgery to fix it, that yes, we can fix the anatomical problem for sure, but that may or may not improve the functional or physiologic problem of urinary urgency and frequency, because some patients will just have an overactive bladder and pelvic organ prolapse. And a lot of times fixing the prolapse will improve upon that, and sometimes it won't. We still have to continue to work on that after we fix the anatomical defect. Some women feel they're not emptying their bladder all the way, or they're getting recurrent urinary tract infections because they're not emptying their bladder all the way. And that goes back to the fact that, you know, that bladder falls and it kinks the urethra. And I told you that urine can get trapped there. So the worse the prolapse get, the higher the risk of that happening. And also with that, women can have a weak or prolonged urinary stream because it's harder for them to get the urine flowing because of that narrowed urethra from the kink. Sometimes it's difficult to hold a position, or they have to posture differently to either get themselves urinating or to have a bowel movement. And we talked about splinting. And some women have to splint for defecating or having bowel movements, but also some women have to do that to empty their bladders in more severe cases. And constipation can be both a risk factor for developing prolapse, but it also can be a symptom of prolapse. So some women won't develop constipation until they've developed the rectocele. But then once they have the rectocele, the constipation sort of gets worse and worse and worse. Fixing the rectocele hopefully will fix the constipation in those patients. Patients that have had chronic constipation even before the rectocele happened are more likely that the constipation was the risk factor leading to the rectocele. And in those patients, ideally, before we ever even consider doing surgery, we get them on a bowel regimen and get their constipation under better control, usually with the help of their GI doctors. So that's really important. Sometimes pelvic floor physical therapy can help with that sort of a thing, as can using a squatty potty, which is a little tool that sits around the base of the toilet. That's very helpful for preventing rectocele recurrence after surgery, helping with constipation, preventing rectocele from developing if you have constipation. And essentially, if I back up a few slides and show you this picture here, again, when you have a normal anatomy here, rectum kind of comes straight down and out. And when you are sitting on toilets the way they're made these days for our convenience, it leaves your pelvic floor and your hips and your knees at not an ideal angle to have a bowel movement. There are some muscles that sit around the rectum, the anorectal junction here. And when you're sitting in a comfortable position for your knees, so you don't have to squat, it keeps that muscle kind of tight around the rectum, and that makes it harder to pass stool. Our bodies were built to be squatting to poop. And so the squatty potty helps try to meet somewhere in the middle with this dynamic. And by putting your feet up on this little stool, it helps to bring the knees higher than the hips. That tilts the pelvis forward a little bit so that you have a more straight trajectory of the rectum, anus, down and out. And it relaxes that muscle around that anorectal junction. And that helps patients not have to strain so much. It helps get things flowing. And then that's how it helps prevent the constipation or rectocele or both. So very helpful to get a squatty potty. You can find them on Amazon. Occasionally Costco has them. Okay, and last little point is fecal incontinence. A rarer thing that I see, it has to be really bad rectocele with bad constipation, and you're just kind of leaking stool around it. So thankfully, that's not something I deal a whole lot with, specifically as it relates to prolapse. There are other conditions which we, can help with that. So if you come to my office and I'm concerned that you could have prolapse, or you come to me being told you've already got prolapse, what I'm going to do is talk to you about your history, wanting to know exactly, how many times were you pregnant? How many deliveries? How did you deliver those babies? What other pelvic surgery have you had? Have you had any radiation therapy for any reason? Diverticulitis, bowel surgery, all the sorts of things. Do you still have a uterus or not? Do you leak urine? Do you have any of those symptoms I just went through? So a very thorough history to try and get a full understanding of what's going on. And then a physical exam is very important. And I will examine somebody even if they come to me being told I've got a cystocele or, by their primary or gynecologist or family practitioner, because I need to see what's prolapsing to be able to best counsel you. And so that means a pelvic exam. A lot of women come in saying, I was not prepared for a pelvic exam, but if you have this type of a problem, your doctor's not doing right by you if they have not done a pelvic exam. So you're going to get a pelvic exam at least on your initial visit, or I'm going to tell you need it. And if you need to come back, that's fine. A urine analysis to make sure you no urinary tract infection. A post-void residual check, and what that means is we use a little bladder scanner and ultrasound to make sure that when you've emptied your bladder, you've emptied well enough, or if not, quantify how much you're leaving behind. And then some women will need what's called urodynamics, and that's a study to try and understand how well their bladder's functioning, what its capacity is, what it contains, and whether or not they have leakage. Some women very clearly, when I'm taking the history, it's clear that they have stress urinary incontinence. They leak when they cough, laugh, or sneeze. And other women don't necessarily have that, or maybe they had it in the past, but they haven't had it in years, or maybe they've already had other surgery for that issue. And we're thinking about maybe fixing their prolapse. The reason to do urodynamics is to try to detect prior to surgery any what we call occult stress urinary incontinence, which is incontinence that may be masked by the prolapse that might manifest after we fix the prolapse. So I'd want to know about it beforehand, or to rule that out with some certainty. And a cystoscopy is occasionally necessary in situations where maybe the patient's already had surgery, it's failed, their history or physical is in some way kind of uncertain, or we need clarification. So it's not standard that I do a cystoscopy for prolapse, but it would be a unique situation that might be required. Maybe the patient's got blood in their urine or is having UTIs, et cetera. We just want to make sure there's nothing else going on there that could contribute or be a problem or a big, I wish I'd have known this before surgery, at the time of surgery. Okay, so moving on to management options. Okay, so there's observation, and observation is when we just kind of watch it. I mean, if it's not causing you too many problems, or if I go through all the available treatment options and you say, you know what, I'm really not that bothered right now, observation is fine, because prolapse really is not a life-threatening problem for most people. It's a quality of life problem. It is very rare that prolapse is so bad that it causes risk of damage to, other structures or, significant sequela. And some of those can be, bad urinary tract infections as a result of not emptying. In really severe cases where you have basically stage 4 prolapse, everything's fallen out. And this is not subtle. I mean, things are hanging out between your legs. You cannot get it back up. It won't stay up for anything. That can sometimes put a lot of pressure on the ureters, which are the drainage tubes between the kidney and the bladder, because they kind of get tugged on and trapped. That can cause what's called hydronephrosis. So that sort of scenario is pretty rare. I've seen it maybe 2 times in the last 5 years. Those patients need to have surgery. Even if they don't want it, they need to have something done to fix it, because it risks injury long-term to the kidneys. But short of that, if you're not really having too many symptoms that we think are necessarily attributable to the prolapse, we can watch it. Conservative treatment would include like sort of non-surgical options, of which there are 2 other than observation, and that is pelvic floor physical therapy and a pessary, and I'll go through those. So pelvic floor physical therapy is where we have you meet with somebody who's trained in proper management through physical therapy techniques of a lot of pelvic floor conditions, of which prolapse is one of them, as well as all the other symptoms: urgency, frequency, pain, discomfort, all those things pelvic floor physical therapists can help us out a lot with. But they'll work with you on specific pelvic floor strengthening exercises and Kegel exercises and different posturing techniques, voiding techniques, both urinary and defecatory techniques, to try and help reduce the symptoms of the prolapse and maybe help tighten things up a little bit. So if you've got a milder prolapse, it may be enough to kind of pull things up a bit. If you've got stage 3, stage 4 prolapses, this is not going to be the right thing for you. But for milder stage prolapse, it can be enough to get your symptoms under control and maybe tighten things up to where if you have very minor symptoms, they may go away. And we also may be able to prevent you from having progression of the prolapse. So that's how I think of pelvic floor physical therapy for this problem. It certainly never hurts to do pelvic floor physical therapy before surgery. It can be very helpful, especially in patients that have a lot of urinary symptoms or pain. And I think that's a really, really helpful tool, is to start with some pelvic floor physical therapy and get you kind of prepped for surgery. And then sometimes we'll also need it afterwards. A pessary is a vaginal insert. It's usually made out of rubber or silicone, something similar to that. And it comes in lots of different shapes, sizes. So for those of you who aren't familiar with a pessary, think of like a diaphragm. And this goes inside the vagina. It's placed generally by the doctor, more often than not gynecologists. Some urologists will do this. I don't do pessary placements myself. I send those out to the gynecologists around town that do them, but they're fitted specifically for the patient. There's not a one-size-fits-all approach to this. Sometimes it requires a few trips to the gynecologist to get the fit right, but oftentimes for milder, moderate prolapse, these can work really well. And it's a non-surgical option that can hold the vagina back up into its normal position, sort of lifting the bladder or pushing the rectum back into their normal positions. And can be also used for patients that have incontinence concurrent with their prolapse. Sometimes these inserts will have a little ring on it that gets a little pressure back to the urethra. More often than not, if you're sexually active, these are going to need to come out to have intercourse. Technically, it's not harmful for you to try to use it, keep it in while you're having intercourse, but a lot of times it'll be uncomfortable for you and or your partner. And it's important to realize that this manages, but does not fix the condition. So if you take it out, the anticipation is that eventually, things will start to kind of fall back down. If not immediately, shortly thereafter, especially if you just get up and start walking around. Some women will keep them in for 3 months at a time and not touch them, especially helpful for our older patients. Other women will take them out, clean them every day, take them out for bed at bedtime because they want to kind of give their vagina a rest, if you will. There's nothing wrong with that. Some women are comfortable doing that, some are not. But typically, we won't let you keep them in for more than 3 months at a time without them being taken out, cleaned, and then put back in, generally done again at the gynecologist. So that's a non-surgical treatment option. One thing to note about pessaries that are really helpful, if I have a patient that comes in and I'm not sure if their symptoms that they're describing, pain, like low back pain, pelvic pain, or even some of their urinary symptoms, like urinary urgency, frequency for milder prolapse, if I'm not convinced that the prolapse is really what's causing it, and they're not complaining so much of the pelvic pressure, pain, or heaviness that I think would really, in and of itself, be a reason to move forward with surgery, then I'll ask the patient to go get a pessary fitting. And that way they can have the prolapse fixed, so to speak, not fixed, but managed, I should say, for that period of time and see, do all their symptoms go away? If their symptoms go away or they're much better, then it lends credence to the fact that perhaps the prolapse is what's causing all their symptoms, and moving forward with surgery, I would feel a lot better about. Or some people say, you know what, I really like the pessary. Forget surgery. I'm happy enough just like this. But if they feel better, but they really don't like the pessary and having to go in and get it changed and all that sort of stuff, or they're sexually active and their symptoms get better, then I say, okay, now I feel comfortable moving forward with surgery because there's a good chance that I've fixed the anatomical problem and all the functional problems get better as well. So sometimes I'll use a pessary for that reason. And then with surgical management, I put here on this slide, there's vaginal and abdominal approaches to this. And the goals of surgery in general are hopefully, and in most cases, to restore normal vaginal anatomy, but also restore normal function of the bladder, of the bowel, and restore normal sexual function. So those are the main overarching goals. And I will say in terms of this, with restoring normal vaginal anatomy, for some women, we'll offer something called a colpoplasis, which is an obliterative procedure. And I'll go through that in just a minute. And in that, the goal of surgery is actually to not restore normal vaginal anatomy. It's to actually close off the vagina. And that has special indications, which I'll get to. But for the most part, when we're doing surgery, the goal is to restore normal anatomy. So in terms of vaginal repairs, we're going to go through the restorative repairs. There's native tissue repairs, there's graft or mesh repairs, and that's got a caveat by it now, because now mesh is no longer FDA approved for vaginal prolapse repairs. So I won't spend too much time on it, but I do want to touch on it because I always get these questions in the office, either from patients who either already had a prolapse repair or they've heard about this sort of a thing in the past. So the thing that I will typically do is what's called a native tissue vaginal repair if I'm going to do a vaginal restorative repair. So with native tissue, what I mean by that is we're taking your body's own tissue that's become thin or weak or torn off its normal attachments and sort of pulling that back together. And what we're doing is what's called a plication. So imagine that your pants split right at the seam where your zipper is and just splits to the side. And now, you know, your belly kind of bulges through that area. Well, the same thing kind of happening with your pelvic floor and the connective tissue structures between your vagina and your bladder. So your bladder's fallen through that defect. What we want to do is find the edges of that tissue that's been torn, you know, in the midline, or sometimes it's torn off one side on the lateral wall. We want to find that and sew it back together and really buttress that tissue so that your bladder goes back to where it needs to be and your vagina stays in its normal position. So that's kind of a basic way of explaining the native vaginal tissue repair. With this, we're not using any kind of grafts, so we're not using human tissue to augment it. We're not using synthetic mesh. We're not using bovine grafts. I use sutures that'll dissolve. Some people will use some non-dissolvable sutures for some of these, but I personally use dissolvable sutures. So that at the end of the day, once you've all healed up, there's nothing left behind that's not your own tissue. So everything will dissolve that I use in there, the stitches. And that reduces the risk of, you know, mesh-related complications or suture-related complications because of, you know, host tissue reactions or erosion or exposure, things like that. Now, the problem with this is that there is a slightly higher recurrence rate compared to repairs that have been done at least with mesh. I can't necessarily say that with human cadaveric dermal tissue or pig skin or cow skin, things like that. But in terms of comparing a vaginal native tissue repair to a mesh repair, patients that have native tissue repair have a higher risk of recurrence because we're not augmenting that repair with anything else that's sturdier than your connective tissue is at baseline, other than the sutures, which eventually dissolve, and then you're kind of left on, hopefully that's holding. So you have the benefit of less complications, but the risk of a slight, you know, higher recurrence rate compared to if you were to have done it with a graft or mesh. But the problem with mesh is that in this type of surgery, so vaginal prolapse repairs, not incontinence and not abdominal prolapse repairs, the use of mesh was taken off the market because there was higher risk of mesh erosion into other surrounding structures like the bladder, or exposure or extrusion through the vaginal incisions that were used to put this in. Oftentimes the mesh could also contract or kind of scar down and get tighter than it was originally, you know, than when it was originally put in, and that can cause contractures or pain. These can get infected. It didn't happen very often. But it can get infected, then it's hard to get out. People can have sort of rejection of these sorts of things. That's thankfully very rare. And so it just never bore out in the clinical studies that using it actually significantly improved people more so than the native tissue repair. And the FDA finally pulled the plug on this not too long ago. And so now you cannot do this. You can't buy a kit of mesh, which they used to have, and put it in. Now, there are some people who'll still do it off label and they have to cut their own mesh to kind of make it fit. Again, off-label to do that. I do not do that. I've never actually done mesh vaginal repairs, thankfully, so I don't have to deal with all the complications of it. But there are people who do a lot of mesh repairs and did them well. And not everybody that had a vaginal mesh repair had a problem. And so if you've had one and you're listening to this, or you hear this down the line, if you never had a problem from it and it worked great for you, thank goodness. And you don't have to worry about it and go to the doctor and get it taken out just because it was removed from the market. So it's more about preventing complications in other people. There are certainly a lot of urologists, urogynecologists who are upset about this, and rightfully so. Probably a lot of the patients who ended up with complications didn't have a very, very super skilled surgeon doing it that has done a lot of these and knows their anatomy. And, you know, that can happen. And there are a lot of great surgeons that did this that had very excellent outcomes with very few complications. But at the end of the day, the FDA made their decision, so it's gone. These are some of the potential complications of any surgery vaginally, you know, and this is not specifically with regards to native tissue repair, biologic graft repair, or vaginal mesh, but I listed some of the potential extra complications down there under those certain things, which I went to. But even with the native tissue repair, you can get bleeding. Depends on the exact location of where we're operating and what compartment needs to be addressed. But, you know, sometimes we do what's called a sacrospinous ligament fixation to tack up the top of the vagina as we're doing the bladder repair. And there are some big blood vessels back there that you can get into. Thankfully, that's really rare. Normally, the vagina is very well vascularized, and that means it heals well. But sometimes patients will bleed during the operation. Usually, it's not something that gets us into trouble or gets the patient into trouble, and it's well controlled because it's right there in our face, and we can take care of it. So, you know, you do need to be consented, you know, that you possibly could use need a blood transfusion. Unless you have reasons to not accept those, you'll probably get that question when you're going through surgery to ask you if you'd be comfortable with it, and that's why. It's just to be on the safe side, it's rarely necessary. Infections can happen, thankfully very low risk, and that would be, you know, an infection of the incision or deeper into the pelvic cavity for some operations where we have to go a little deeper. Damage to the bladder or the ureters. So the ureters can get trapped in the repair of this with sutures. We always look inside the bladder, at least I do every time I do one of these at the end of the case to make sure I still see nice flow of urine through each ureter, and also to inspect the bladder to make sure I didn't injure it or come too close to it. As you heal up from these, regardless of if you're using mesh or not, or grafts or not, even with just a normal native tissue repair with sutures, you can get scar tissue that develops that can cause pain with intercourse. It's going to be a little bit higher risk when you're using the grafts or the mesh. But that can happen even with a native tissue repair or any kind of surgery down there on the vagina. Recurrence of prolapse, like I said, it's going to be higher risk with native tissue repairs than it is with the vaginal mesh or graft repair, maybe minimally more than the graft repair. Failure of symptoms to improve. So that's a big one people need to understand. We can treat the anatomical problem, and that's what surgery is all about. Fix the anatomical prolapse so that when we look in there, it looks nice and the vaginal canal looks nice and open and you don't have anything protruding through it. But again, you may not have urinary symptom improvement like urgency, frequency, because there are patients who have prolapse, there are patients who have urinary incontinence or overactive bladder or just urgency or frequency, and they can coexist or they can be mutually exclusive. So the goal of the surgery is repair the anatomical defect in hopes that the bladder or other symptoms will get better, but we cannot guarantee that going into surgery. In fact, sometimes we can make it worse, especially for a short period of time while you're healing. Difficulty emptying bladder can happen, and usually that's transient just because the bladder is so stunned by what we just did to it that it just doesn't want to squeeze well right after surgery. And a big one is the development of stress incontinence. So that's coughing, laughing, sneezing, and you leak. And again, that leads back to the preoperative urodynamics to try and predict whether that's going to happen if somebody doesn't already have that symptom before surgery. But if you take a urethra and bladder that looks like this and it's kinked, and then you lift the bladder and you got that nice funnel effect, if the urethra is not very well supported, you know, prior to surgery, it's kinked, and when you cough, sneeze, the urine can't make it out because it's kinked. But once you lift it, now you're going to expose that defect, and the patient might have stress incontinence. So I do warn patients about that. A lot of times we'll do preoperative urodynamics to try to address it. If the patient's already not emptying their bladder well or having a lot of problems with incomplete emptying, retention, and UTIs, a lot of times I'll stage it just to make sure, okay, we fixed the prolapse, now what do we have to deal with? And then we can fix whatever's left over, and it makes it much less difficult to understand why somebody might not be emptying their bladder well after surgery in that scenario. So that's kind of a special case there. The obliterative vaginal surgery, which I mentioned earlier. So with this, the goal is actually not to restore normal vaginal or typical vaginal anatomy. This is to actually shut off the vagina. So we'll only use this in patients who are no longer sexually active, or in patients where they're just too ill or frail to be able to undergo a more significant operation like the vaginal repair or the next operation I'll tell you about. So that's called a colpocliosis. Again, with this, we're shutting off the vaginal canal, and how that's done is basically sewing the anterior and posterior vaginal wall together. It's not a commonly utilized surgery because of the fact that it basically is completely closing off the vagina, but it can work really, really well with very low long-term recurrence rates, things like that. And then an abdominal sacrocolpopexy is an excellent procedure that offers really high long-term success. And this is, again, a restorative procedure, but it's not done vaginally, it's done abdominally. And the main, let's see, I thought I had a picture here. Well, I do this sitting on the robot. That's me right there sitting on the robotic console. And the robot is a great tool for doing this type of a surgery, but it doesn't always have to be done robotically. But it's done through the abdomen, either through an open procedure where you do have an incision similar to like a C-section type incision, or robotically laparoscopically, which is where we do everything through little small incisions about the size of my finger there. We have a few of them across the abdomen, and one for my assistant who helps me, and she's phenomenal. So what we do with this operation is go from the inside and create a plane between the vagina and the bladder, and the rectum and the vagina on the anterior and posterior walls respectively. And then we also create a plane overlying the sacral promontory, and there's a ligament there, a very sturdy ligament that we can use to help tack the vagina back up into its normal position. And so with this, we do use typically a mesh product. There are people that can do it with maybe cadaveric fascia. I have not done that yet. At some point, maybe I'll try that. But for the most part, this is the gold standard of treatment of apical prolapse when it occurs with or without anterior posterior wall prolapse. But specifically when the top of the vagina is affected, this is a fantastic operation. And once you've got that plane created between the vagina and the bladder, and the vagina and the rectum, you lay on a piece of mesh. This is going to be a very similar mesh to what was used vaginally, a polypropylene mesh, a sterile, surgical grade, non-absorbable, flexible mesh. And in fact, I might have one here I could show you. I thought I did. Yep. So, well, actually, I have a sling, but you can kind of see the mesh, what it looks like. So it's very thin, pliable. This would be something for stress incontinence, but the material is the same for prolapse. And we just lay it on the vaginal wall, anteriorly and posteriorly, and sew it into place. So the beauty of this operation is that we don't make any cuts on the vagina, okay? And so you don't have to have a big incision that you lay the mesh through and then sew the vagina up that then has to heal. This is laid on the vagina without any incisions into the vagina, typically, and sewn into place. And then the tail of that mesh, which is in the shape of a Y, that Y tail is tacked to that ligament, and that helps restore normal vaginal anatomy and access. And, you know, it's a great operation. It offers very high long-term success. Typically, patients, you know, have very little pain from it. It can be performed as an outpatient surgery, but for the most part, I keep patients overnight just to observe them. And With the vaginal repairs, same thing, can be done as an outpatient. I'm more often going to send that patient home than I am when they've had the intra-abdominal surgery, but sometimes I'll keep both patients overnight one night. And this gives a much sturdier result, meaning it has much less likely chance of recurrence long term. And again, it just goes back to the fact that we're using the mesh to help augment the repair, because the mesh is always going to be stronger than your tissue, which is already shown that it's got some inherent defect, and that's allowed the prolapse to occur. With any of these operations, the recovery is about 6 to 8 weeks of no vigorous lifting, no vigorous physical activity or lifting more than about 12 pounds, no intercourse for 6 weeks, no squatting, jumping, all those sorts of things. We want you walking right after surgery. So you don't get to just hang out and chillax for 6 weeks. You do need to be up and moving. We just don't want you doing all that stuff that's going to have you really straining your pelvic floor and causing a recurrence. So it's basically any of the things that I talked to you about that can increase your risk for the prolapse. We want you avoiding those sorts of things. Coughing. We don't want you smoking anymore if you're a smoker. We want you to be ginger for those 6 to 8 weeks while it heals, and then you can get back to your normal activities. The incisions for this, if we do it robotically, are all about the size of my finger. So, chance of hernia is very low. Chance of an infection is not zero, but knock on wood, I haven't seen a wound infection in quite some time. Because we're going in through the intra-abdominal space, there is going to be a slightly higher risk for injury to organs inside of the abdominal cavity. So that would be a bowel injury or injury to the vascular structures. We're always on the lookout for the ureters when we're doing this operation, just to make sure we don't get too close to them or accidentally suture them into our repair. We know, we're expecting the scar tissue from prior hysterectomies when we're doing this or other surgery. We always ask those questions pre-op so that we kind of know what we're going to get into. I will say that the way that I do the sacrocolpopexies is not the way that everybody does sacrocolpopexies. I typically will have a hysterectomy done at the time if I'm going to go with this approach and the patient has not already had a hysterectomy. There are some surgeons who will offer a uterine sparing sacrocolpopexy. I have not gotten into that yet. I'm not sure that I am on the bandwagon. I think if the uterus is part of the problem, I typically will recommend that it go ahead and come out. That way it's not kind of trapped in the mesh. But there are differences of opinion about that. And so there are some people who will do uterine sparing sacrocolpopexy and feel quite comfortable with that. If I am going to have a concurrent hysterectomy, that would be done by the gynecologist. And I work with a few around here very well to sort of combine these operations into one. So that's how I manage that situation. But most patients that have this are already coming to me and they've already had prior hysterectomy. So, man, that was a lot. I'm almost out of time here, but I want to see if there's any questions that the group has. So let me just take a quick peek here if I can get this to work. I don't see any questions. That's good. If anybody has any questions, you can feel free to pop them in through the little, I think, sidebar on the webinar. And if you have, real personal questions or something that you think, I didn't touch on that may be pertinent to you, I am more than happy to see you in the office. You can call, and you can see my website here. You can go to the website to get our number or call 512-231-1444 for an appointment, and I will be happy to help. So I hope that was informative and that you guys got a lot out of that. I know it was a lot of talking, but that's what you're here for, is kind of hear the spiel. And if you, have questions, concerns, please feel free to reach out, and I will do my best to help take care of you. All right, y'all, signing out. Dr. Mobley. Bye-bye.